Good morning, everybody, and welcome. Welcome to our second JBI Evidence-Based Healthcare Symposium, the JBI Solution Room. It's such a pleasure to be here with you all today. My name is Zachary Munn, and I'm the Director of Transfer Science at the Joanna Briggs Institute, and it's my pleasure to act as a chair of today's proceedings for this event. Now, before we get into this event, I would like to firstly acknowledge that today's event takes place on the traditional lands of the Kaurna people. And I wish to acknowledge the Kaurna people, the original custodians of the Adelaide Plains, and the land on which the University of Adelaide's campuses at North Terrace, Waite, Theberton and Roseworthy are built. Now, I'd also like to thank our major sponsors for today, SA Health, who we have partnered with for today's event and who without which this event would not have been possible. And particularly I'd like to thank Jenny Hurley for all her work in supporting this event as well. So, good morning. We are certainly in for a fantastic event here today in this beautiful building. Now, you have all come here today with questions, problems, and perhaps challenges that you have encountered when trying to get evidence into practice. You are all wanting to get evidence into practice, my kind of people, and we have heard these problems and we can empathise. And I can say to you today that you will hear some solutions to these challenges. It is my pleasure to introduce the Executive Director of JBI and my boss, and what a fantastic boss she is, Professor Zoe Jordan, to the stage. Now, Zoe is an experienced academic, business and communications professional with a long history working in evidence-based healthcare. Now, it has been a huge week for Zoe, and in addition to the normal busy work of successfully running JBI, she has also been awarded the South Australian Telstra Businesswoman Award for Academia. A very well-deserved honour, yes. It would seem we are in the perfect place to celebrate, perhaps with a glass of champagne after this, Zoe. Please join me in welcoming Zoe to the stage.
The irony of my job is that I hate being front and centre. So how many people in the room have actually seen the JBI model? A few. Okay, well that's good. JBI staff can put your hands down. I know you've seen it. Okay, so to start with the pebble of knowledge in the middle of our model, which to us represents evidence-based healthcare, we conceptualise evidence-based healthcare as decision-making that is cognisant of the feasibility, appropriateness, meaningfulness and effectiveness of healthcare practices. So when we talk about clinical decision-making, any of you who work in a clinical setting will appreciate that all of those things come into play. So even though something might be effective, there are other things that will impact upon whether or not something can be implemented in practice. There are lots of interventions that have been proven to be super effective, gold standard from an effectiveness perspective, but there are other reasons why they're not necessarily implemented at the point of care. And there are lots of examples of that, and I'm sure that you can all think of them. So the mattresses to prevent pressure ulcers, very expensive, can't be used in all contexts. There are some groups with religious backgrounds where they would not necessarily want a blood transfusion, so from an appropriateness perspective, even though it might be effective, it's impacted by that. So lots and lots of other examples too. So that's a really important part of evidence-based healthcare from a JBI perspective. So I'm just going to quickly work around the model, and as we've heard a few of the speakers talk about today, in order for any kind of change to be sustainable, we really have to be talking about implementing evidence that comes from clinical practice. So there's no point in us going and trying to force a change upon a group of people who aren't going to be engaged. So from a JBI perspective, it's really important that the knowledge needs of people out there working in practice are being addressed in order for it to be sustainable. And engagement, and from my perspective, empathy is a really, really big part of that. I'm assuming that many of you, have some ideas about research, but in order to answer some of the questions around feasibility, appropriateness, meaningfulness and effectiveness, different types of research are utilised. So questions of effect might be answered by doing studies that are RCTs, but that's not going to work for more experiential questions around how clinicians and patients experience different interventions. And equally, where there is no research evidence, that doesn't mean that we suddenly don't make decisions. And so it's really important to us that we utilise other forms of knowledge that are available to us, and they might be discourse, it might be experiences that are published in the forms of commentaries by experts. And JBI has developed systematic review methodologies in order to be able to do that in a really rigorous way. So obviously we do systematic reviews, but equally evidence summaries have become more popular or rapid reviews as a streamlined approach to synthesis. And we have heard Ian talk a little bit about the rigorous processes around guideline development. But what use is any of that if we're not getting it out to the people who really need to use it? So transfer, evidence transfer, is the next wedge. We refer to them as wedges in our model. We have heard some discussion this morning around active dissemination. Passive dissemination is still really important, but we feel that active dissemination is something that's really, really important to the evidence-based endeavour. And active dissemination is changing, and Ian and I have just been having a conversation around Twitter and teaching people to tweet. We've been encouraging all of you to tweet. I will put my hand up and say that I am a terrible tweeter. My team have, they're constantly trying to teach me how to tweet appropriately and teaching me about handles and hashtags and all those sorts of things that are a bit beyond me. But social media is increasingly playing an important role. We need to be engaging with champions, decision aids, infographics. There's a whole different array of communication strategies for dissemination. Equally, seeing evidence embedded in clinical decision support, policies, processes, and education. And again, not just necessarily in services, but CPD, award courses, non-award short courses, which I'll talk to you about in a minute. All sorts of education is required. And finally, really, the piece that, this is where the rubber hits the road, isn't it? And the piece that is the focus of today, and that's evidence implementation. Now, from a JBI perspective, we talk about context analysis, and we have heard our speakers this morning talk about context analysis and determining the readiness of a unit or facility or organisation for change. Facilitation, finding those champions, leaders. We're going to hear from some of you after I've finished talking. And evaluation. What's the point if we're not evaluating whether or not that change has in fact been successful? We all know that healthcare is complex, life is complex, and so none of this is a linear process. You'll see that we have put in some arrows that go each way, but in fact the reality is probably looks more like that. So what we've tried to do is put it into a pretty neat picture for you to articulate all the things that we think are important. But we know that healthcare is complex, and each of these things are not easy to achieve, and most of you will probably start a change process at any point. So you're not necessarily going to start at one point and neatly work your way around. And so we do talk about culture, capacity, communication and collaboration as being overarching themes for the model. So JBI runs two programs. Our evidence-based clinical fellowship program, which is all about getting evidence into practice, but also our comprehensive systematic review training program. So everything that JBI is all about is, working out how to synthesise the best possible international evidence and then how do we get it into practice. And we want to be able to teach people how to do those two things. And we have a train the trainer program for both, because what we found was that these are skills that people are really interested in and they really want to learn about, but we just don't have capacity with our team of 2 people. 2 minutes left. Oh, no. So we now run a train the trainer program so that our centres around the world can be teaching people in their different regions. So the evidence-based clinical fellowship program focuses on advanced education and training in practical approaches to identifying using clinical evidence in healthcare. We talk about using the best available evidence, but it is also about being cognizant of clinical expertise and patient choice. And just talking through FAME, I think you can see how all of those things really interact with each other. The aims of the program, we've got some key elements underlined there. So we're talking about implementation. We often know what needs to change, but we don't really necessarily know how to do it. So this program is really about, okay, let's work out how we do these things. The objectives there, okay, so the focus is on, firstly, what works or what helps with evidence, getting evidence into practice, and then how do we know whether or not what we're currently doing aligns with the evidence, and sometimes that's fully, sometimes that's partially, and then how can we evaluate it to see if we've improved once we've gone through a process of implementation. Equally, as part of this program, now the program runs for 6 months. We do a residential week at the start and a residential week at the end. And in that first week, we do a day that Zach alluded to earlier around clinical leadership. We all, I think, agree that clinical leadership is a really important part of any endeavour around implementation. There's some things up there around what we talk about during that workshop. The core concepts really of this program are, yes, around implementing evidence, around identifying barriers to change, working out what the process of change is going to be, what strategies can you identify with your team in order to see that practice is changed. So we've got a quote up there that is from the National Institute for Health and Care Excellence, NICE. Their definition of clinical audit is a quality improvement process that seeks to improve patient care and outcomes through systematic review of care against explicit criteria and implementation of change. Probably many of you have seen that. The JBI model for clinical audit is obviously against the best available evidence. So defining what best practice looks like in accordance with the best available evidence, measuring what your practice looks like in relation to the best evidence, and then working with teams, engaging teams at all levels. So bearing in mind that clinical leaders are not necessarily the people at the top, and believe me, I'm the first person to say that the leadership is not always just about who holds the top position. Leaders come from all sections of an organisation. Doing a baseline audit against that evidence, working through the process of change, and then re-auditing to see if you've made any difference. And of course, JBI has software to help you do that. PACES, which, just to note, we are completely rebuilding this year. No pressure, Zach. PACES is the practical application of clinical evidence system. So it's a really basic tool, a very intuitive tool that helps to walk you through this process of evidence-based clinical audit and feedback. Professional outcomes, being able to design and do a project. You know, I think the thing that probably most of our clinical fellows would say, or that we say to them, is you're not going to change the world. This is not going to be, you're not going to reach all of the goals that you perhaps had set, and they always come with huge goals in mind. But it's learning a process that can be ongoing and can be applied to different problems. And we hope that there is some personal growth for the individuals that go through the program, that there's a change in attitudes, in knowledge, that they gain skills, that maybe they change their behaviours in order to be able to generate some really high quality clinical outcomes. So I've just finished with hardships often prepare ordinary people for an extraordinary destiny. And I think that the people that go through this program are really brave. Anyone who embarks on a process of trying to change practice, when we are talking about dealing with teams who have been doing things in a certain way for a really long time, is hard. And it's hard to be the person that puts your head up and, sticks your hand up and says, actually, I'm going to be the person that helps to make that happen. So I would congratulate anyone, and I certainly congratulate these three wonderful women on taking on that challenge, and they've done a wonderful job, and so I hope you really enjoy listening to their presentations. Thank you.